There we go. All right, well, let's start. Let's go for a minute through the things that we're going to talk about today. We have a number of topics we're going to discuss today. First of all, we're going to set the landscape here by talking about what's happened post-election. We're going to also spend a little bit of time talking about the new Congress and what is going to happen with the new Congress and its impact on health reform. We will move on then to healthcare policy in Virginia, which I know is important to many of you. And then finally, we're going to get to some more substantive issues, such as a key that may have a little more direct impact on some of you as employers and providers, the healthcare aspects for providers, as well as some of the compliance issues that those of you that are employers are going to have to be dealing with over the next 4 or 5 years. For employers, healthcare reform presents both challenges and opportunities. For employers, it's a challenge because it's going to require them to rethink the way they provide healthcare benefits to their employees. Really, the status quo is over on this one. But it also presents an opportunity because employers will have the chance to develop a long-term benefit strategy and around their total rewards packages. Well, let's set the stage now by having Mike Farrell begin with how we got here legislatively and where we may end up. Mike is a partner in our federal government relations practice in Washington, D.C., and he is very well versed in all of these issues, so I'm going to turn it over to Mike.
Thank you, Kate. Good morning, everyone. Also want to welcome Brendan Dunn, who is sitting to my left. For those who are viewing this on the screen, we very much appreciate you participating, Brendan, in this, and I'll yield the floor to you in a few minutes. I did want to make a few comments, though, and as Kate said, set the landscape, set the table, if you will, with respect to how we got here and what is in store in the lame duck session, which will convene next week, and then in the new Congress as well. As this header on this slide indicates, elections really do matter. I think we can change it from a question to just a affirmative statement, declarative statement, that elections do matter. And when we look back at how this bill, how the Affordable Care Act became law, we can see that the elections played a large role in this because the Congress used an arcane budget device really to pass health care in the first place back in 2010. As you know, the Senate rules require a 60 votes to close off debate. And the Senate majority, Democratic majority, was able to avoid the filibuster by using this device. They only needed 51 votes instead of 60 to pass. And in the next slide, you can see that what we have here is sort of chronological or sequential description of how the bill became law. And it's really started back in 2009, as we know, first few months of the new Obama administration, and it proceeded until until March 21, 2010 on the next slide. Some key dates in here, I would just draw your attention to those. You can see just how close this bill was closely debated, followed, filibustered, and ultimately approved. I think the most important date, however, on this second slide is really November 2nd, 2010, because that is when really the floor fell out of the Democratic majority, certainly in the House, and really ushered in 2 years of very strident opposition to the new health care law. November 2nd, the House majority shifted to Republican control. And in the next slide, the political fallout, as I said, was very swift and devastating to the Democrats, who lost the House. Republicans gained control following the 2010 elections. And there were several legal challenges. And again, this slide demonstrates just the importance of a single vote, for example, in 3 cases, ultimately leading to the Supreme Court case decision in June. The law was either declared constitutional or unconstitutional by a single vote. And as we know, with the president being reelected, he may have as many as 2 or 3 new appointments to the Supreme Court, depending on whether any of the justices choose to retire in the next 4 years, and that appears likely. What next? What happened after these votes? Well, before we move to that slide, let me just make a comment here, is that in the House, after the Republicans took control in 2011, there were 32 votes, again, just to show just how the tenor, the atmosphere had changed, some 32 votes to repeal either the entire law or sections of the law. And so really the dynamics of this law, not only did it face legal challenges, but political assaults as well. All those attempts to overturn the law in the Congress were rebuffed by the Democratic majority in the Senate, but it doesn't mean that those fights are over. So what's next? Well, we had an election about 3 days ago. The president, as we know, was reelected. I think the Romney campaign just conceded in the last few hours Florida, which means the president increased his electoral total by 29 votes, 332 now electoral votes. And so the Congress, too, has changed. And here we have a slide that shows the differences in the composition of the House and the Senate compared to the 112th and the 113th Congress. Right now in the House, the trend, if all holds, the Democrats will pick up 7 seats, move to probably 200 seats, still in the minority, but better than where they stood a few days ago. Republicans will have about 235 seats as it stands right now. Interestingly, the number of women, for example, in the House has increased by as many as 5 seats. So there could be 76 women in the House of Representatives, again, a new record there. Over in the Senate, I think everyone is surprised by the luck of the Democrats. They really did have the lucky charm this year. They have increased their seats by 4. A year ago, Brenda and I were talking, no one would have bet that the Democrats would have retained their majority status in the Senate, but they did. And interestingly here too, women now will comprise 20% of the Senate, with the election of some additional 3 women to the Senate. So again, major changes. So what did the elections mean in practical and political terms for the Affordable Care Act? Well, Brandon's going to drill down on this and talk a lot more about what it means and what the Congress may face in the next few weeks, as well as in the next 2 years. But I think what we can say with relative certainty is that the law is bulletproof at this point. It's highly unlikely that it's going to be overturned, at least by Congress. Implementation is going to proceed. We were talking about whether the administration, or for that matter, the country, is ready for 2014. Brendan will talk a little bit more about that. But in saying that, that doesn't mean that these challenges are going to just drift away. In fact, the House Majority Leader just yesterday vowed to bring up additional votes to repeal sections of the law, perhaps the law itself. So that drama will continue certainly in the House. I don't know whether the Senate will follow suit. I'll ask Brendan that too. And that there are still, I think, a couple of court challenges out there that the Act will face. But I think too that the law has got to be tweaked. No law is perfect, as we all know. They often have technical corrections bills that correct some of the errors that they make. So we'll see whether or not in the next 2 years bring some perhaps improvements or changes, needed changes to the Act. I want to hand off now to Nicole Pugar, who is our Government Affairs Director in Richmond for the firm. Nicole, take it away. I just note that in the Post today there's an article about what we were just talking about, the insurance exchanges and the governor's decision. I don't want to steal your thunder here, but the governor's decision not to set up an exchange. So
right.
Take it away.
Okay, just a brief housekeeping reminder, if everyone could mute their phones or turn them off, we'd appreciate it. Thank you. Thanks, Mike. And as Mike said, I'm a part of our Virginia Government Relations team here in our Richmond office, and it's a pleasure to be here, and thank you all for coming. As Brendan and Mike kind of alluded to in their comments, The Affordable Care Act, while a federal law, a lot of it was left to the states to implement. And so I'll just touch briefly on what it is that Virginia is doing, but more importantly, what Virginia is not doing, as Mike said. I think that's the bigger story. And a little bit about how politics have played into this, because it certainly has been a big piece of our decisions. So, sorry, slides. Oh, no, let me go back. There we go, okay. Let's start with the administrative branch. So when the law was first passed, Governor McDonnell asked that a stakeholder group be convened, and this group was called the Virginia Health Reform Initiative. And essentially this was a group of stakeholders, including the hospitals, healthcare providers, insurers, anyone who had a stake in the game. And he asked this group to basically make recommendations to him of how to implement the law in Virginia. So that group met for about 2 years. In its first year, it had recommended to the governor that Virginia create a state-based exchange. And that became legislation. The General Assembly passed that legislation in 2011, and the governor signed it. So our statute now reads, it is the intent of the Virginia General Assembly for Virginia to have a state-based exchange or exchanges. That's when politics come into play. So after the General Assembly in 2011 and then into the spring of 2012, that's when the presidential election starts to heat up and rhetoric about who's going to become the nominee for the Republican Party starts to begin. And we see that Rick Perry, then governor of Texas and chairman of the RGA, announced his intentions to run for president. And so with that, Governor McDonnell became chairman of the Republican Governors Association. And as you all probably well know, the Republican Governors Association was one of the main stewards in opposing the Affordable Care Act and calling for its repeal. So as you can imagine, as chairman of this association, Governor McDonnell is towing the line and speaking with the association and says, okay, Virginia is no longer going to implement a state-based exchange. The Virginia Health Reform Initiative is no longer going to meet, and we are not having anything to do with the Affordable Care Act. At the same time, politics are brewing, and our Attorney General, who is one of the leaders of the stop of the Affordable Care Act on the Attorney General's side, is arguing his case before the Supreme Court. And as you all know, the outcome of that, we now have 2 members of our administrative branch, both the governor and the Attorney General, vehemently arguing that the Affordable Care Act should not be implemented and that Virginia is not going to implement it at all. So again, this becomes political. With that announcement and his name in the national spotlight, Attorney General Cuccinelli felt that it was the right time for him to announce his intention to run for governor in 2013. Now, this came to a shock to many because in 2009, Lieutenant Governor Bowling then said, I'll step aside and let you, Governor McDonnell, run for governor, or Attorney General then, run for governor. So now, Lieutenant Governor Bowling, who had always said that Virginia should run its own exchange because he didn't see where we should ever relinquish power to the federal government, is forced into a situation where he knows that he has a party opponent who is saying, I'm not going to have anything to do with the Affordable Care Act, and he has to say something. Well, again, politics comes into play. And as you all know, politics is local, and Attorney General Cuccinelli, who is probably the more conservative of the 2 candidates between him and Lieutenant Governor Bowling, would appeal to local Republicans, knowing that he would be more favorably elected in a convention. And that's one of the points on the slide. And so he appeals to them and he wins, and it's decided that we'll have a convention to elect our nominee for Republican governor. And so now the lieutenant governor is forced to say, well, knowing that I need to win the hearts and minds of those who are going to potentially elect me in a convention, I'm now going to be opposed to the Affordable Care Act as well. So that sets the stage. All three of our leaders in the administrative branch are opposed to the implementation of the Affordable Care Act and basically are saying we are not going to move forward with a state health exchange. And in fact, as Mike alluded to, Governor McDonnell reinforced his position this past Wednesday, actually. It came out in our Richmond Times-Dispatch. I don't know if any of you saw it here locally. But when asked whether, now that the election is over, when we know that the Affordable Care Act isn't going to be likely to be repealed, what's Virginia going to do? His exact quote was, "I don't want to buy a pig in a poke for the taxpayers of Virginia." Without more direction from CMS and some answers to the 30 questions that he, along with the other Republican governors, asked the president in a letter earlier this year, that he didn't feel it was in the best interest of Virginia to create a state exchange, and we would default to the federal exchange. So that's where things stand at the administrative level. But as you all know, our Virginia General Assembly, our legislative branch, has a say in some of these things as well. So let me give you their perspective on things. In our House of Delegates, first of all, I have to correct the slide, and I apologize for this, but it does read that we have a 30-30 division and we have a 20-20 division, but just to put that on the record. But in the House of Delegates, moving backwards, the House of Delegates is dominated by the Republican Party. They have a 68 majority with 32 Democrats. And they, I would say probably within the last year, after 2011 when they approved the law, in the last year have rallied behind the governor and said, we are not going to implement this law. And so with their dominance in the House of Delegates, I don't foresee anything happening in the House of Delegates. I know that our Democrats are going to be very much united in asking for legislation to create a state-based exchange. They feel that's the right way to go. They feel like we should implement the law. But with their minority of 32, I just don't know where that's going to go. Especially we have a speaker who's very much opposed to the implementation. The Senate is a little bit of a different story. Like I said, they're split 20-20, and that gives them the ability to negotiate a little better. I won't say that they always negotiate well, as I'm sure you probably have all read. There's been some partisan politics there as well. But there's some room for horse trading, if you will, as we call it, and I could foresee if this becomes an issue that that people are really concerned about, and that the patient advocacy groups, the hospitals associations, the medical providers rally around, and we can find one united bill that we really think is the right way for Virginia to go, that there could be some horse trading. And transportation is going to be another issue that dominates the Virginia General Assembly. I'm not saying that this is going to happen, but potentially we could see a vote from a Republican for a Democrat for a transportation bill in exchange for a Republican vote on the Affordable Care Act. We just don't know how that's going to go. Senator John Watkins is the leader of this in the Senate. He's here from Central Virginia. He represents parts of Powhatan, Chesterfield, and the city of Richmond. And I recently, in conversations with him, he is steadfast in his movement towards making sure that we consider this in the 2013 session. So I think you'll see some talk of it in the General Assembly. Where it goes, I don't know. Again, we have to be mindful that our governor is very much opposed. So, and he ultimately signs what becomes law. I just want to talk very, very briefly about some other players behind the scenes who I think have some influence, one of which is Secretary Hazel. Secretary Hazel is a practitioner. He's an orthopedic surgeon, and he comes from it at the perspective of a provider, and I would say oftentimes doesn't always necessarily agree with the administration's position, and you can sometimes hear that in his comments. An example of this is recently the state had the option of whether or not they would apply for a grant to implement an exchange, basically the money to create the IT infrastructure for a state exchange. And knowing that the governor probably wouldn't like this idea because it was advancing the idea of implementation, he instead said, hey, we're not going to make this a grant about, or accept this grant to implement the law. we are going to make this about improving our Medicaid eligibility system. So we got the grant, which is great news, and now we have a system in which the Medicaid eligibility determination is much better at the social service level, a social service agency level. But I would say, and I think a lot of us would agree, that that infrastructure, that IT infrastructure, can definitely be expanded to create an actual exchange. So while it was carried off as a Medicaid eligibility system, I think it's definitely a little bit more than that. And so the other group that I just briefly wanted to touch on that has a lot of influence, and I think this is a group where you'll see they'll raise some questions that our legislators in the General Assembly who are opposed to the Affordable Care Act might get a little squeamish when they raise these questions. And I can't say that they would because they're a regulatory body if not asked, but I can guarantee you folks will ask these questions. The Bureau of Insurance has, like I said, are the regulators, and so they have the ability to say who would be a part of the exchange as providers, as insurers, and also what regulations they would fall under. And so one of the regulations that I think most, that the folks haven't really thought about, but definitely have come up in the mind of the Bureau, is how and who is forced to pay for abortion. Now, you all well know this was a very hot topic button issue at our last General Assembly session. And the Affordable Care Act says that the provider shall pay for an abortion. I can foresee if this question is raised to some of our Republican legislators, there would be some real eyebrow raising and folks getting a little worried that if they cast a vote for us to accept a federal exchange, what does that mean in terms of coverage for issues that they may not want, abortion, but others as well, that they may not want to be associated with. So I think in the debate, you'll see some questions raised that could potentially, because of political reasons, sway some legislators. Let's just move on to the final slide here, Medicaid expansion. I probably wouldn't have, before the Supreme Court ruling, wouldn't have been talking about this because it wasn't to be left to the states. But because of the Supreme Court ruling, as you well know, this is now a decision that the states have to make. And I can tell you again that our governor is opposed to the idea of us expanding Medicaid. And basically, you'll see the reason for that. I'm not going to go through all of these numbers because it's certainly too much to go through, and I think Wyatt may touch on some of this. But what I would call your attention to is that first bullet that says Virginia ranks 48th of 50 in terms of our eligibility, that meaning what we provide and who we provide it to. And I would say that we would be one of those states in which the cost of the expansion would be the greatest. Now, initially, the federal government is said to be able to cover that cost. What you'll hear our legislators argue is that after 2020, we, the state, are responsible for that. And the price tag for that is $52 million, an estimate at the state level. That number varies. You'll see a lot of different numbers. It depends on what you're including and what you define as the essential benefit. But that is a price tag that most of our Republican legislators will say, and our governor will say, we can't afford that. So I don't think that you're going to see any push for an expansion of Medicaid in Virginia initially. I will tell you, however, that in conversations with regulators, CMS, our Virginia Medicaid director, Cindy Jones, will often ask the question, what if we expand to 100% of federal poverty level? What does that mean? And what will the federal government give us the subsidies that they say they would at 133%? So I could see some debate potentially about partial expansion, and I'm sure that'll be coming more to the forefront as more states get more direction from CMS, as Brendan and Mike alluded to, is hopefully coming down the line soon. So with that, I'll turn it over to Wyatt, but I'd just like to say before that I do project the General Assembly will definitively say that we don't want a state health exchange. I'll say that politics, again, is going to be an influence in this, and the key thing to remember here, both as providers and as purchasers of insurance, is that 2013 is an election year for our Virginia House of Delegates, and they're going to listen to their constituents and the folks that help support their campaigns. So I would say if you are somebody who wants to see a state-based exchange, this is your opportunity to exert that pressure. And again, politics plays into everything, and who knows what's to come. So with that, I welcome your questions, I welcome your calls, and I'll turn it over to Wyatt.
Great. Sure. Thank you, Nicole. Good morning. My name is Wyatt Beasley. I'm the chair of the healthcare practice here at Williams Mullen. I'm going to take this off the screen. There we go. I'm here today to talk about the impact that healthcare reform has on healthcare providers. Frankly, this is a topic that my partner Dick Rich and I could probably spend the rest of the day talking to you about, but I understand or realize that most of our attendees really are employers or folks interested in healthcare reform from other aspects. I know we do have some providers, but so I'm going to limit my comments to a few bigger issues so that we can get Bryden up here to talk about the employer's aspect. But it is an important piece of healthcare reform, the impact on providers, because the changes that it's going to require providers to make or the impact it will have on their practices or their everyday business is going to be significant over the next few years. And that will probably then translate to changes on the type of care we receive as patients or the manner in which it's rendered to us. First point I'm going to make about healthcare reform and providers, frankly, is that up till now we've really had just kind of a state of confusion. Ever since the act was signed into law, we've had challenges to it. We had the Supreme Court challenge, then we had a presidential election in which repeal of the act was a fairly dominant theme. For providers, hospitals, nursing homes, physicians, it really left a huge cloud of uncertainty. They know the act requires some significant changes to the way they're going to practice, to how they're going to be paid, to how they collaborate with other providers, but they didn't know, was this ever actually going to happen? We're there now. I think there's obviously going to be changes in the way, or there could be changes in the way that the act is implemented, that the regulations are put forth, that type of thing. But from a provider standpoint, their perspective, I think most understand now that it's full speed ahead, that the major initiatives in the act are going to happen in some fashion, that there's going to be changes, and that need to start preparing for it. Frankly, it's going to present some significant challenges for every stripe of provider, no matter what they are. From the provider's perspective, the challenges, however, may include some opportunities. Just as Kate said, there could be some opportunities for employers with respect to rejiggering their plans and taking care of addressing some of the things that the act allows. For the providers, if they can sit back and analyze what the act is going to require of them and where there may be required changes, there may be some things they can do now to prepare for it, and also some advantages they'll get out of it over time. Advance the slide here. The first significant piece of reform for providers that I'll talk about today is the expansion of coverage. Nicole just talked about it a little bit, and obviously there's a great deal of, I don't know, not confusion, but at least we don't really know what the Commonwealth of Virginia is going to do on the two big issues, one of which is Medicaid expansion and the other is a state exchange. But I think we can all count on something happening in both respects. I can't imagine that the politicians are going to say we're going to refuse all this federal money and not expand Medicaid. I think that's going to be tough to do. And whether we have a state exchange or a federal exchange, there's going to be an exchange whereby those who are uninsured right now can move into some form of coverage, whether it be Medicaid or a commercial coverage through an exchange. Now, this is important. It's obviously important for those who are uninsured, but it's very important for providers too, because depending on the type of provider and who their patients are, they may suddenly have just an increased demand for services. Primary care physicians, for example, it's projected that the demand for their services is just going to increase significantly. What's 420,000 people moving onto the Medicaid rolls. Right now, we don't have enough primary care physicians out there. So those of us who wait an hour to get that care, we may see some real issues when we roll in there and there are more patients there. So providers need to prepare for that, and that may be involving recruiting additional physicians and taking part in building up the pool of physicians out there. For some providers, they may see better reimbursement. Those who are right now taking care of a significant number of uninsured patients. Some of those patients now be covered by Medicaid. Now, granted, that's not the best reimbursement rate, but it's something versus less than that they're getting now. Or they may suddenly have some of their uninsured moving into the commercial payers, commercial insurance through the exchanges. So there may be some benefits for the providers. It just depends who they are. The opportunities, I think, for providers are, to the extent that they are currently taking care of a number of uninsured or a significant number of uninsured patients, determine is there a way to promote enrollment. To the extent that you can promote folks moving on to the Medicaid rolls, or hopefully, more importantly, moving them into the exchanges and getting that coverage so that the provider's reimbursement can be better. That is an opportunity. Another opportunity, frankly, is, and Nicole just hit upon it, determining your point of view on the exchange, whether you want a state exchange or a federal exchange. I'm not going to speak to that, but I think providers need to get involved in that now, because it will have an impact on the type of insurance that will then be reimbursing them later. And they've got an opportunity to get involved in that, whether it's the political process or once that decision is made, for example, if it's a state exchange, getting involved in the development of the state exchange. In other words, they really shouldn't stand by and let it happen without them. Another significant impact of healthcare reform is changes in reimbursement, and this is going to be a recurring theme over the next couple slides, frankly. Obviously, as Brendan spoke earlier, Medicare and Medicaid are a significant portion of our spending, our government spending, and there are going to be a lot of efforts to cut that spending. And how we get there, no one really knows. But I think if you look at the Reform Act and what's going on in the federal government, there's no doubt there's going to be pressures to reduce Medicare spending for care. And in fact, the Act puts in place several initiatives and programs that shift payment policies, at least for Medicare, away from what we call fee-for-service into a model that, several models, but one of the models is focuses on the value of care and efficiency of care and cutting costs. We think over time that more of the commercial payers will follow Medicare's lead. They're already doing it, and they'll follow along and push initiatives that really require physicians to, or providers and overall, to cut their costs, find ways to cut costs, find ways to be more efficient. When you combine that with the impact of potentially having a greater Medicare patient base, you can see that many providers may be looking at a significant reduction in their reimbursement over the next few years. For providers, they've got opportunities. They've got to identify now where there may be areas where they can cut costs or where they can develop efficiencies in the rendition of care and address those issues now, and maybe identify, are there opportunities to collaborate with other providers where they can work together to work through the continuum of care and address those costs and try to reduce their costs so that as the reimbursement rates drop or their overall reimbursement drops, they're not hit as hard. Quality of care is going to become a big issue under the Reform Act. It already is. And again, the key there is that the Reform Act has several policies or programs in it that tie the amount of reimbursement that providers receive to the quality of care they're rendering. There's, for example, we've got programs in place that, to the extent the hospitals have patients get readmitted over a period of time after an inpatient episode, that they'll get dinged for, get penalized for the readmission. In other words, they lose money that they would have otherwise been reimbursed. There's policies like that all through the program. Tied to that also is that there's initiatives in the Act which will require, maybe not require, but emphasize or encourage public reporting of the quality of care that providers are rendering. There'll be efforts for transparency in that, so patients and others can get on a website and see the type of care that's being provided, how it's being provided, the type of quality. For providers, this is really, they've been moving this way for years, but now the federal government is getting involved in it. And the key, I think, for providers, the opportunities is now, at this point, try to identify what are the measures against which you're going to be held or judged. Try to address those now. Determine what they are. see what steps you can do now to begin the process of improving the quality of care. Recognize what tools you may need to have to make that happen. Frankly, I think the biggest tool, and this has been going on for years now, is information technology. Switch to electronic medical records so that you can really track the type of care that's being provided. It requires a lot of money, and for a lot of providers, that's a big issue. And so there may be a need to develop some kind of strategic alliance with another provider and other providers. There's lots of opportunities there, but those are the issues that providers need to be thinking about and dealing with. The shift in reimbursement to a focus on efficiency and cost and quality of care, I think over time is also going to lead to some shift in the overall delivery system with healthcare. Right now, historically, providers have been really operating independently. You have physician groups who have historically been independent of hospitals. You have the hospital, you have the nursing home, you have all the ancillary providers, and generally they are operating independently of one another and providing care independently of one another, although the patient may run through the entire continuum of those types of providers. There's been a move over the past few years to try to at least manage that care through that whole process, whether by bringing all the groups together as one or just affiliating in some fashion with respect to the rendition of care. The Reform Act really pushes that even further and implements some pilot programs and other policies that will require, or at least initially encourage, better coordination of care and a focus on efficiency by different types of providers. And over time, that may become less of an encouragement and more of a requirement. We'll have to see. Examples of that are accountable care organizations. I'm sure you've probably heard about those, patient-centered homes. The key to these initiatives really is to bring together the disparate types of providers and make them responsible for the treatment of a patient through the entire continuum of care. It may go so far as bundling that care and paying that group one reimbursement and letting them figure out how to pay for it internally, measuring them all together with respect to quality of care. It's a broad range, and it really is going to change the way providers render their care and look at how they work with other providers. The opportunities again is determining how you can manage across the continuum of care and choosing your partners wisely, I think. That frankly is an individual level decision, so I can't give great advice on that at this point. The last part, big issue or significant impact to reform that I'll talk about, frankly I think presents more challenges than opportunities or benefits for providers, and that's regulatory enforcement. Anybody who's been involved in healthcare for the past 10, 15 years has seen the federal government and the state government ramp up their enforcement activities. Medicare is by far the largest payer in the healthcare system. As a result, there is fraud and abuse in the Medicare system, and there's a perception that it's maybe pretty widespread. I think you can quibble over that, but there's certainly instances of fraud and abuse. And as a result, the federal government has poured a lot of money into developing enforcement activities and their ability to reach out and grab folks who are either committing fraud or just being overpaid for their services. The Reform Act continues this tradition. In fact, if you look at it, there's just a number of provisions which will greatly enhance the enforcement ability of the federal government and the states. Some of the big ones include they're going to devote $350 million over the next 10 years to enhancing regulatory enforcement. And that includes hiring more regulators, hiring more investigators, hiring more prosecutors. In addition, they're going to expand overpayment recovery efforts. Anybody who's involved in healthcare in the past 4 or 5 years has heard about Rex and Mike's and all these third-party contractors who CMS contracts with to go audit provider records and determine if there's an overpayment or if there's fraud, and pursues those providers. The Reform Act is expanding that. And then lastly, the Reform Act enhances civil penalties against providers who violate the law. And to the extent those violations rise to the criminal level, the Reform Act increases the criminal sentencing, makes the sentencing tougher. I say this, and I point this out, again, not so much to say that it's an opportunity for providers, but really to emphasize to providers that this is a time, this only enhances the federal government's ability to pursue enforcement, and those providers who haven't to date really looked at their compliance efforts need to and should take some time to do that. I'm going to hand the program now over to Brian DeWitt, who's going to talk about the opportunities for employers and the challenges they're going to face. Thank you.
Good morning. Well, since March 23rd, 2010, I've been giving talks similar to this one. And usually the reaction I get from the audience is, well, okay, that's fine, kind of complicated, but this isn't really going to happen, right? I mean, the Supreme Court's going to strike it down, or it's going to get repealed. And then 2 years later, last summer, when the Supreme Court upheld the law, there was a kind of a shock that it wasn't struck down. But then it was back to, well, still, it's probably going to get repealed. And my response was always, well, you know, technically it is a law of the land, and we need to start getting ready for implementation. Well, now, today, I can stand here and say it definitely, you know, is the law of the land, that we do need to get ready for compliance with the Affordable Care Act. And so I thought it would be a good idea this morning to go through kind of a laundry list of the items that are coming up over the next 2 years, 2013 and 2014, as far as what employers, sponsors of group health plans need to be doing over the course of the next 2 years. The first one, the immediate item, is the cap on employee salary reduction contributions to health flexible spending arrangements. Effective for plan years beginning on or after January 1, 2013, the maximum amount an employee can contribute to a health flexible spending account is $2,500. This cap does not apply to employer contributions. And again, it's a plan year rule. So if you have if the employer has a fiscal year plan year that runs into 2013, the $2,500 cap doesn't apply until their plan year beginning in 2013. So if you have a July 1 plan year, the $2,500 cap will apply to the plan year beginning July 1, 2013. If the plan has a grace period going to 2.5 months after the end of the plan year into 2013, reimbursements during that period also do not count against the $2,500 cap. Plans, we are generally amending our clients' plans now for this change, but there is relief. Employers have until December 31, 2014 to actually amend their plans retroactively to comply with this rule. Additionally, in 2013, there was an additional Medicare tax of 0.9% on income or wages, $200,000 or above, or $250,000 for married couples. As of March 1, 2013, and this is going to be kind of interesting, employers must give notices to employees informing them of the availability of state exchanges in 2014 and the possibility that the employee could be eligible for the premium tax credit to help them pay for insurance through an exchange. As we've heard this morning, there's a lot of uncertainty about the exchanges and whether states will have them or whether we'll be ready to implement. So although it may seem like we have until the end of 2013 to figure that out, employers have until March 1 to figure out what their notices are going to be saying. And then also in 2013, we really need to be preparing for 2014. And 2014 is when there's really full implementation of the Affordable Care Act. The idea is that most everyone beginning in 2014 will either be covered through employer-sponsored coverage or they'll be purchasing coverage through a state exchange or a federal exchange if only 20 states implement the exchanges. The individual mandate was the subject of the Supreme Court decision over the summer and it got a lot of attention over the last few years. The flip side of that is the employer shared responsibility requirement. Employers with at least 50 full-time employees, and that means an employee who works 30 hours a week or more, are required to provide coverage or minimum essential coverage or they're going to face penalties. If an employer fails to provide any health care coverage at all, then and an employee whose income is 400% or under the federal poverty line goes and purchases coverage through an exchange, then the employer is going to owe a penalty equal to $167 times the number of full-time employees in excess of 30. So an employer with 50 employees would pay $167 a month times 20. If the employer offers inadequate coverage, so if the employer has a plan, but it doesn't meet the standards of the Affordable Care Act, then the penalty is $250 times the number of employees who receive coverage assistance through a state exchange. So an employee who's under 400% of the federal poverty line, who's a full-time employee, goes to an exchange, purchases coverage, and receives premium assistance through the exchange. If that occurs, the employer would owe a $250 penalty per month for that employee. Coverage is inadequate if it's unaffordable, which means the amount the employer requires the employee to pay exceeds 9.5% of household income, or if the employer cost of health coverage, if the insurance coverage covers less than 60% of the health insurance costs, then the plan fails to meet the standards of the Affordable Care Act, and the penalty, this inadequate coverage penalty, would apply. And so, of course, in 2014, we discussed the health insurance exchanges, and then people who are not covered through their employer will face a penalty if they do not enroll in coverage on their own. And so some other items that are coming into effect in 2014, the first is the automatic health plan enrollment requirement. Employers who have at least 200 employees will be required to automatically enroll new hires into their health plan. The Act does not specify which, if you have different tiers of coverage or different options under your plan, the Act does not mandate which one you use, but the employer is required to have a default election into a health plan if they offer a health plan. And then existing employees during open enrollment need to be defaulted back into a plan. So if an employee fails to respond to the open enrollment, they're not, a lot of employers default them into no coverage. In 2014, you'll be required to default them into coverage, and we're expecting regulations giving us more details on this. Additionally, in 2014, the maximum eligibility waiting period for health plan enrollment will be 90 days. And the clock starts running when the employee otherwise becomes eligible for coverage. So let's say you have a plan that only covers full-time employees, and a part-time employee has been working there for a year. That year of employment doesn't count. Once the employee becomes a full-time employee and eligible for the plan, that employee must be enrolled within 90 days of becoming otherwise eligible for coverage. Third, the pre-existing condition exclusions for adults are eliminated in 2014. With passage of the Act in 2010, plans were prohibited from imposing pre-existing condition exclusions on children under age 19. In 2014, that rule then will apply to everyone. In 2014, there will be an increase in the maximum reward permitted under a wellness program. Currently, under the HIPAA regulations, the maximum reward for participating in a wellness program is 20% of the cost of employee-only coverage, or if spouses and dependents can participate in the wellness program, it's 20% of the cost of employee plus spouse or family coverage. Under the Act, that limit is increased to 30%, so you can start giving greater rewards to promote wellness in 2014. And the Act also authorizes the Department of Labor and Health and Human Services to increase that limit even higher, up to 50%. So it's this push on preventive medicine to prevent, to reduce costs. So in 2014, we're at least going to have an permitted increase in wellness program rewards up to 30%. Currently, under the Affordable Care Act, there is a small business tax credit to help small businesses. That's employers that have 25 or fewer employees and have an average payroll of, or average per employee wages of $50,000 or less. There's a tax credit of up to 35% of the cost of providing health coverage. In 2014, that maximum number goes up to 50%. The amount of the credit is is phased out as employers get larger. The maximum credit is for employers that have 10 or fewer employees. Right now it's 35, it'll go up to 50, and then it phases out up to 25, and then after 25 there's no credit. There will also be uniform premium rating rules in effect in 2014, so in the setting health insurance premium rates, there are only certain factors that can be considered. Is it employee coverage, employee plus dependent coverage, age, geographic location, and tobacco use are the factors that can be used for setting insurance premiums. Additionally, insurance companies and self-insured employers will be required to contribute to a reinsurance program. And then employers also will be required in 2014 to start reporting whether they are providing minimum essential coverage. Minimum essential coverage has yet to be defined. It's based on what we've heard from the government so far, that it's probably going to be based on the small health insurance market in each state. And they're going to look at the 3 top health insurance offerings for the small group market in each state and have standards then for minimum essential coverage, looking at what items are covered, what are the co-pays, what are the deductibles, and they're going to come up with a definition state by state as to what minimum essential coverage is. And so those are just, I know I went through this pretty fast, but those are the items coming up between now and full implementation in 2014, and I'll turn it back over to Kate.
Well, first of all, thanks to all of our speakers. I think you've gotten a lot of information from this. We'd like to present the opportunity for there to be some question and answer period, and we will go sort of from office by office, starting first with our Virginia Beach office. And Kiki, would you see if there's anybody who has a question for any of our speakers?
Yes, we have a question. 1 moment, please.
Hi there. I was trying to figure out how we should set ourselves up in 2013 for when you're trying to make decisions on health costs and health care for your employees. I guess this was for Mr. DeWitt. I don't know if you have any ideas or how we can get ready for it.
Well, I mean, the real question for 2014, getting ready for 2014 is, the big question is whether it makes sense to continue to offer employer-sponsored health coverage. There's, the penalty, the maximum penalty would be $2,000 per employee in excess of 30. A lot of employers say, well, that's cheaper, that's less than what we spend on health care. Currently, we'd rather just pay the fine and send employees to the exchange. But if you think about it, the reason employers provide health insurance is really to be competitive, to retain and attract quality employees. And so if you're right out the bat in 2014 as an employer that's going to send everybody to the exchange, you're putting yourself at a disadvantage to attract employees. And so the thinking is there's going to be a lot of wait and see, and nobody really wants to be the first to do it. But it's also anticipated that health insurance costs are going to continue to increase, and the cost of providing health insurance is going to increase. And that pressure is going to start pushing employers towards sending employees to the exchange. And so more and more people will be covered by the exchanges. Now, the experience that we have, despite what Mitt Romney may have said, his Massachusetts, the Romney Care was, it's the same deal, right? So in Massachusetts, you had they call it the connector instead of an exchange, and there's an employer mandate. And the penalty in Massachusetts is less than the Affordable Care Act. And what they saw in Massachusetts is actually, since implementation of Romney Care, the number of employers offering insurance increased. So it was the opposite of what a lot of people thought would happen. So I think it's really, it's a cost issue. Getting ready for 2014, you need to get with your lawyers, obviously, and your consultants, and determine, do we have to do anything to our plan? The 60% of cost requirement. Well, most decent health insurance, if it's worth anything, it's going to meet that requirement. And so how much are we requiring employees to pay for it? And do we already satisfy the requirement? And if not, what is it going to cost to get ourselves in compliance? And if it's, then you weigh that against your position in the marketplace to attract employees.
Yeah, and I think on the marketplace concept, employers can't look at this in a vacuum. So if you're just looking at what does it cost me to provide this insurance versus what does it cost me to send my, for my employees to go to the exchange or to pay the penalty, the fact is that if going to the exchange now costs your employees a great deal more money than the premium cost, then your employees, particularly your valuable employees, will be coming back to you saying, I've just taken a huge pay cut, so you need to rebalance my compensation. So there's most of the consultants and people who are out there discussing this are saying you need to view all of this in terms of your total package of compensation before you make a decision. You can't just look at it in isolation.
And that's interesting. There was a survey conducted last year, and I forget the percentage, but the overwhelming majority of employees surveyed said that they expected, if the employer dropped the health care coverage, to get a pay raise. So,
Kiki, do we have any more questions of Virginia Beach?
Anyone
If not, Mike, do we have any questions in DC? Anybody in Richmond? Patty has a mic, so we'd be happy to take some questions from folks here in the audience. We've got a couple, so.
Nicole, I was curious to know if the Medicaid infrastructure expansion is working through DMAS, if that's where the expansion has occurred.
That would be the agency in which the implementation of any expansion would...
Right. Is it DMAS is, the...
Right, the Department of Medical Assistance Services.
Right.
Mhm.
Is that where is that where y'all have expanded that program and the infrastructure that you're talking about?
The IT structure.
The IT structure.
That I mentioned.
The IT structure, so that you can, push
Yes.
out from there. My
Correct.
wife works for one of the local insurers, the mid insurers, who are ramping up to insure the oncoming new Medicaid enrollees.
Sure.
And it's it's not the pure Medicaid folks, and it's not the folks who qualify for insurance. It's the folks who are in between,
Right.
who hopefully they'll raise the
Eligibility level. To answer your question, first of all, yes, the IT structure would be housed at the Department of Medical Assistance, but also in the social service agencies, so anywhere where anybody who potentially is eligible for Medicaid would go. Most of those are in communities, but it is under the auspices of the Secretary of Health and Human Resources, Secretary Hazel. He has the authority to decide what those agencies have in place in terms of the IT structure to determine eligibility. The question, I think, that your wife would probably want to be answered is, do we foresee that expansion? And I would say, as of our governor's comments most recently, no. But I think, as my colleagues have alluded to, I don't know that we can continue to stick our heads in the sand and say we can't do anything. Without getting into too much detail, there's reductions in the amounts that hospitals and providers are paid when Medicaid eligibility expands, as it was written into the law, and those are set to still be implemented, DISH, if anybody's familiar with those. So I think without us expanding to some degree, there's going to be this really large pool of people who are going to fall in between a gap, and that's going to really be bad for
Well, and that's what I was alluding to. And secondarily, I want to. Secondarily, I was hoping that reimbursement's going to be a serious issue, and if reimbursements don't keep up with inflation, and with physicians' needs, we're going to have a lot of physicians dropping out of the program, and refusing to provide services to these individuals, whether or not we have no matter how many students come out of medical school, and no matter how many PCPs are out there, they're still going to start showing up in the ERs, and that is one of the programs that my wife happens to monitor are the ER programs, and are so many significant costs are borne in the ERs.
Absolutely.
And unfortunately, that's where the massive costs are to handle minor costs, minor injuries, and minor things that can be handled at doctors' offices.
Absolutely.
Where we don't have suitable or physicians who are willing to provide those services because reimbursements are so low.
That's right.
And how are we going to address?
That's addressed somewhat in the Act, at least on the primary care level. There are, in the Reform Act, for both the Medicare and the Medicaid level, there's initiatives to increase reimbursement for primary care physicians. And that's part of the idea of trying to expand the number of primary care physicians that are out there. But past primary care physicians, they're really, we're still looking at the doc fix that Brendan referred to earlier. We've got a potential of a 26% cut in Medicare for all physicians coming pretty soon. Now, they kick the can down the road on that every year, and that may happen again this year. But that's out there. And you combine that with the other changes to reimbursement in the Reform Act, it's a significant challenge for providers.
It is.
We have a couple more questions, I think. One at the...
Thank you. Brendan, I have a question about what constitutes a full-time employee. I think there's some rules on the number of part-times that constitute full-time. And my other question along those lines is, how in the world do you, if you have employees as we do that are hourly employees, and the whole concept of average household income when that household may not be W-2ing everybody, the wife may be just working for cash or whatever. Can you discuss that whole concept?
Well, I'll start with the household income. That is a problematic area. The IRS has floated some ideas, such as just using W-2 comp as a safe harbor to determine what the household income is. Of course, that's going to, in a way, shortchange the employer, because if the spouse is working, household income is going to be higher. But that is an issue. And then, if the person goes to the exchange and they establish that their household income is at a lower level, the employer may have had no idea, when they set their insurance premiums. So that's something that needs to be worked out between now and 2014. A lot of things, I think, early on, the IRS, the government did a great job of giving us regulations on the early implementation of the Act. There seems to have been a lull through the election, and I anticipate there to be more guidance coming out. A full-time employee under the Affordable Care Act is an employee who works at least 30 hours. And the IRS, just in the last month or so, issued guidance as to how you determine who the full-time employees are for purposes of the Affordable Care Act. And there's this concept of basically, to boil it down, they call it a stability measurement period, a standard measurement period, and that's a look back. So in 2014, you will look back into 2014, you look back into 2013 for a look back period of either 3 to 12 months. And over that period, determine who your full-time employees were, who averaged 30 hours a week during that period, whatever that measurement period is. And then those will be your full-time employees for what they call a stability period going forward. And the stability period has to be at least 6 months, but no less than the duration of your look-back period. So there's this look-back, you determine who your full-time employees are, and then you treat those employees as full-time or part-time, whatever they come out to be, for the stability period going forward. You reach the end of that stability period, and then there's a look-back.
I see where Yum Brands has made it, and we're in the restaurant business, has made a statement that they're going to take everybody to 30 hours or no more than 30 hours. Is that, since you're in the business of giving advice, or maybe not, or would you suggest that's a strategy to follow if you're concerned about your health care costs, if you're in the restaurant business?
It's not illegal to do that. I mean, there's no requirement that you employ anyone any number of hours, and a lot of, I've been hearing that employers are thinking about doing things like that to get under the 50 employee threshold. But, I think before you get to that point, you need to look out, maybe in your case, employers need to look at their current plan to see how far off are we from compliance, or are we already in compliance? Do we have to make how much more expensive will it be for us? So make that determination before you start making determination of reducing hours and staying under the threshold.
We have a question up here, Patty.
Thank you. I'm Chris Beach with Beach Benefits, so I consult with a lot of clients on these issues, and this is for Mr. DeWitt. Since the discrimination rule has been put on hold until further guidance, what I wanted to find out, though, is with regard to the wellness rewards, the factors used to determine the rewards, and the presence of value-based benefit plans, how does that impact the perceived contribution to the employee? Say, for example, a non-smoking employee gets 75% contribution toward their benefit plan, but if you take a smoker, you would charge them more. Now, will that factor into the discrimination rules, or how is that going to be approached?
Well, those wellness programs will not cause the plan to fail, non-discrimination. We currently have, for self-insured plans, the non-discrimination rules, and those plans are also allowed to have the HIPAA-compliant wellness programs that offer these rewards without violating those requirements. Just to back up, the Affordable Care Act made fully insured plans subject to the non-discrimination requirements that apply to self-insured plans. So once we get regulations from the IRS on this, the Section 105H of the code will apply to all health plans, employer-sponsored health plans. And basically, the rule is you have to offer coverage to at least 70% of your employees, and then among the employees who are covered under the plan, all benefits offered to highly compensated individuals also have to be available to non-highly compensated individuals. So there's a coverage requirement and there's a benefits test. And so all plans are going to be subject to that requirement once we get regulations. But we haven't gotten those regulations yet.
Any other questions?
So if I understand what you're saying correctly, for all those that are eligible, you have to offer it to at least 70 of those. Can you bifurcate, meaning you can say, okay, 30%, we're not going to offer it to you and I'll take the penalty, and the other 70%, like if you have different classes of employees, say like hourlies that are 40 hours a week, you say I'm not going to offer it to you and I'll pay the penalty? And for management, I'm going to offer you a plan?
There are currently, under Section 105H, there are rules that allow you to not count people who haven't worked a certain number of time, or people who are part-time versus full-time, and you can also create bona fide business-based classifications of employees to meet that coverage test. So, and we're, one of the reasons I hesitate to answer because we haven't gotten the regulations yet. So we're looking for, guidance along those lines as to how you can, carve up your population and still meet the coverage test. So, but just the general rule is that you'd have to offer coverage to the 70% of your employees. There may be some ways to not count certain employees in that mix. But generally, if you have 70, yeah. So, but if you offer management a richer plan, then you're going to have a problem. And this isn't the exchange employer shared responsibility requirement. This is a separate non-discrimination requirement that will result in excise taxes and taxable benefits to the highly compensated individuals. So it's a whole other. You have to stop thinking about the employer shared responsibility, and this is a whole entirely different bucket. to meet the non-discrimination rules. But again, we're still waiting on regs.
Right, but I think generally the rule would be that you probably cannot, as a matter of, you won't be able to just carve out your corporate folks and all the people that are highly paid and put them in a very rich plan and take your other folks who are in a lower paid category and put them in a bare bones.
Right. As we advise our self-insured clients, you have to have a fair cross-section of employees in your classification. So you've got high pays and low pays, and then some sort of a geographic difference. You got a group in Roanoke and a group in Virginia Beach where they're going to we have two separate plans for them, or they do different functions within the company. So there has to be some logical, bona fide business reason to defend against the IRS saying, well, this is really just a way to give the high paid richer benefits.
Are there any more questions? Do we have anything up from the chat room? All right, well, thank you very much. We really appreciate everyone coming here today. I think from my perspective, having had the ability to hear Mike and Brendan talk about some of these issues has been phenomenal. We certainly appreciate your attendance, and we look forward to the next time. Thank you.